Thank you very much indeed, Claudia. Thank you for that very kind introduction. So, obviously coming the last speaker, most of the work has been done, and I'm happy about that. I'm happy to follow the GPA director, Chris, Mahira, Joe, all the important guys. Everything is done. However, when it comes to a patient, we've been told that there are variations in clinical presentation, in genetics, etc., etc. But when the patient comes to the doctor, they are looking for treatment. It doesn't matter whether you are in Greenland, in Egypt, in South Africa, in Kenya, or wherever. I'm particularly lucky to be working in Kenya because we see all the several shades of skin. So we are able to see all these things. And the last speaker talked about beta blockers. It's not that common, but the books do say it occurs. I think it's something that you remember, but you are unlikely to probably see it so much. One other misconception is that dark races are the same. They are not. If you go to West Africa, and I think we have many Nigerians here and people from Senegal, they do not have as much psoriasis as we have in Kenya. So there is a variation. And of course, Chris, you have very many things to look at when you are addressing the GPA, and it's exciting that we have people here. So the call to optimal care is an old one. Actually, when the UN was started in 1948, that was one of the definitions, that you should have good care wherever you are, whatever situation you are in, irrespective of even of your financial capability. Again, it is a rolling call. Much more particularly, and this has been mentioned by our speaker, Sylvia, thank you very much indeed. There's a landmark resolution, WHO 67.9. And this is probably one of the last diseases that you are going to have as a resolution, because the spectrum and what is changing in the WHO and the International Health Administration is changing, because they are not going to be addressing single diseases. It is important. That came up, obviously, when the resolution was done without any problems, unanimously. We discovered that we needed data to back our resolution and the work being done around the globe. And therein came the Global Psoriasis Atlas, started by IPC, ILDS, and of course, IFPA. And thank you very much indeed, Chris, for the work that you continue to do. We thank actually IPC, Christy, Peter are here, because you are also assisting us in a very, very big way to do this. Obviously, this is a continuing call again for optimal care. If you remember about the United Nations, the Sustainable Development Goals, 3.8. This again was adopted in 2015. 2019, there was a high level at the UN about universal health care. And again this year, we are going to be talking about the same thing also at the General Assembly in New York. World leaders have agreed that health is a precondition of sustainable development. And we want now governments and healthcare workers to look at psoriasis or care as an investment, not just as a consumption. That when you invest in health, you are actually investing in production, because you are making people productive, you are reducing the comorbidities, and thereafter also reducing the cost of care later on. Joe Lambert mentioned about that, about the value. Value goes up when the numerator is higher. When you have better outcomes, then of course value goes up also. No, currently, okay, we talked about history, but currently, 2023, there have been great progress in research with the development of topical treatments, biologics, biosimilars, etc. However, this is not something that everybody will talk about all over the world. We have been told that there are, of course, valuations in presentations, valuation is what, but we were told here in Chile that some people have to fly for and drive maybe for 14 hours. Yesterday we had in our symposium with IFPA that in Philippines, they have 7,000 islands. And somebody would have to be in a boat for a day, then in a bus for 10 hours. Many, many patients will die before they probably ever see a doctor. And some of those will be, unfortunately, psoriasis patients. So I agree with what Chris said, that we are probably investing wrongly. We need to have a paradigm shift and invest wisely. How do we do that? How many dermatologists are there? Yes, there are many, but they are not well distributed. And what we are doing in several places is actually investing in GPs and what others might call clinical officers or physician expanders. They could be nurses. They can be trained to recognize and be pretty proficient in actually the picking up of diseases. Those ones who are being diagnosed as tinea corporis, syphilis, HIV, leprosy even, and being kept on the wrong treatment for many years. That is wrong investment. So we need to change because obviously, with all the development, these inequities, inequalities are also limiting the access. We are talking about access to care. And care will be a little bit different from treatment. Because treatment is much more specific, but care is much more broad and much more passing. Chris has mentioned about the GPA study in South America. And it was probably one of the best studies that had done, and it's exciting listening to this every time. That a whole continent, Tatiana is here, and the team, I think that was great. One of the things, of course, you found is that there is limited access to effective treatment, including biologics. Not just that, but also care. Chris has demonstrated that in Tanzania, which is just about maybe 300 kilometers from where we work, with some colleagues I see here, they didn't see any patient in the Maasai group. But in the clinics we run in Nairobi, in the Psoriasis Association of Kenya, we do have Maasai. So sometimes generalizations will not work. We need to invest at the bottom. You know, the bottom-up approach, not from the top, because you get actually better outcome. Sylvia, we are using your thing. Actually, this is again from the GPA. Very good work done. While many treatments for psoriasis are available in South American countries, it's also probably distributed. And if we are taking treatment as an example of care, it is probably the same thing. So there's need for improvement in the access to more effective psoriasis treatments, including biologics. If we can give examples, I do not think guidelines would be useful to be in a continent like Africa, which is so varied. We can have country-specific guidelines, which are more realistic, because you know what you are able to afford. If you are considering countries like, and I give a poor example like Burundi, which uses only something like $89 for health per capita. You can compare that with the US, which uses maybe about more than $12,000. Kenya uses just about $100. So you have to be very, very wise to have those dollars expand, not just for psoriasis, but for everything. So we need to spread those dollars with care, not just providing, say, biologics, because they may not necessarily be fully accessible. We have in my country, Kenya, we have biologics, but how many are able to access them? There are very few. But we have all the others. We have methotrexate, it's probably the most used. Cyclosporine, also used. But even then, somebody may take long before they see somebody to prescribe those things. So we need to bring them up to the front. We need to bring them sooner than later when they already have many, many comorbidities. So it is important. So when we are talking about the treatment and holistic care, it is good that we go beyond the clinical endpoints. We need to complete patient-reported outcomes in study designs. This is something that has been lacking. But I'm sure now this is something that is going to be current. This is something that is actually now going to be in regulations everywhere, where patients also have to have an input in all these things. Of course, we'll still have to have evaluation improvement overall, like this one. But again, also, we were told if you are using such things, there are some parameters that are very, very poorly defined, and you are unable to use them correctly. But again, we are happy to have GPA, which is leading this thing. And again, also IPC, the many, many master classes that you've conducted, and I'm happy I am seeing some IPC fellows from Kenya here. This is very encouraging. We are using these master classes students to teach nurses, clinical officers, and GPs. So it has a multiplier effect. Yes, Peter, this is happening, and we are so, so happy to be doing this. So, beyond access, we need patient-centered approach. We were told about the integrated patient unit. That is very, very good if you can afford it. But even in places that do not have all the resources that Joe talked about, we can still attempt to do something like this. We can have teams, and we are also organizing such in Kenya, where actually patients also are asked, because when you have patients' input, then they are likely to be more adherent to the treatments that you recommend, to the care that is recommended, and also they will also be able to tell you what is able they can possibly afford. We are discussing, of course, unfortunately, I think it's only maybe about a week ago, that the National Health Insurance is going to include much more people than before. And that is also going to be a plus, because we also have succeeded in the essential drug list in Kenya to introduce basic drugs that were not available before. And this is because of patient-driven advocacy. People push. Doctors are not very, very good pushers because sometimes they only address the patient. And we are having very, very good results also. So in advocacy, in particular, you've answered health coverage. Obviously, when you are talking about UHC, we had today's lecture at the IFPA forum. We were having an address from the WHO regional representative. Now, the target is changing. They are talking about the 3 dials, the $3 billion dials. And this is going to be something. Instead of just talking about the 2030, whatever, it is changing. And it's changing for the better so that we can have safe and effective medication. So even as we are looking for care, and care has to be multifaceted, we have to include several other groups of workers. One of the things that, of course, cuts across all these things is well-being, screening for comorbidities, and that can be done by people who are not as trained as other people in this room. We can teach people to do this and pick things much earlier before they come over. Of course, what are the measurements of our well-being? We launched last year the Wellness and Happiness Report at the UN, again also pushed by patients' advocates and the Happiness Institute. That it's not just that feeling. We've been told about suicidal ideation. That doesn't come out in many measurements. Obviously, this is something that something that we need to address. We are looking to the day when you can have single medication. It has happened. We know it. When we started seeing HIV patients were taking 12 tablets. Now, they are taking only one tablet. Now, the treatment in most parts of Africa is free to the patient. Of course, still be maybe a little bit more expensive. These are lessons learned. We've learned lessons also recently through the COVID pandemic, that we can actually spread our knowledge and our skills further with the teledermatology. And IFPA has also, again with the IPC, given webinars in teledermatology. This is something that also helps to multiply the few dollars that we are able to get. So in summary, the path to optimal care is addressing the access barriers, integrating patient-centered care models in whichever form, wherever you are, and striving for better outcomes for every patient, and advocating for global change, that we invest wisely and you invest in the right place. With that, we invite you to this IFPA conference, which is coming next year, where we'll be addressing more issues about psoriasis. And it's going to be exciting, and you are all welcome. Thank you very much indeed.